Good afternoon. Thanks so much for joining us. We're going to wait a couple more seconds before we get started to let a few more folks sign on. Okay, thank you so much. Thanks for joining us today for our webinar, Making the Connections, Understanding the Impact of the Opioid Epidemic and the Implications for Our Work. My name is Laura Altman. I'm the director of the Illinois ACEs Response Collaborative at Health and Medicine Policy Research Group. We are honored to have Carole Warshaw and Gwen Packard join us today for this webinar. And I know we have a number of new folks in the audience from all over the country. So for those who don't know us, Health and Medicine Policy Research Group works to promote social justice and challenge inequities in health and healthcare. We are an independent policy center in Chicago that conducts research, educates, and collaborates with other groups to advocate policies and impact health systems to improve the health status of all people. This webinar is put on by the Illinois ACEs Response Collaborative, and Health and Medicine is the lead convener of the collaborative, which is a multidisciplinary group that utilizes the science of ACEs and childhood trauma in an effort to create critical transformation to policy and practice that promotes resilience, healing, and thriving. We have a number of resources on our website. You can find policy briefs, environmental scans of trauma-informed programs. We also have all of our past webinars, and you can sign up for our e-newsletter there. And we will include a link at the end of the webinar. We are hoping to have time for Q&A at the end, so please feel free to type in your questions in the chat box throughout the webinar, and we will get to them at the end. And then after the webinar, you'll receive an email with just a short evaluation, ways to participate in the collaborative, links to our website, and a recording of the webinar as well. So that's all the kind of background logistics information. So I'm excited now to introduce our speakers today. They have asked me to keep their bios brief in the interest of time, so we will send out their full bios afterwards because they are very impressive. But Dr. Carole Warshaw is the director of the National Center on Domestic Violence, Trauma, and Mental Health, and she has been at the forefront of developing collaborative models and building system capacity to address the mental health, substance use, and advocacy concerns of survivors of domestic violence and other trauma. She is also very familiar with Chicago and Cook County, as she was on the board actually of Health and Medicine and also worked for part of the county for 30 years. We also have Gwen Packard, who is a training and technical assistance specialist with the National Indigenous Women's Resource Center. And she has worked for many years in Indian country, both at the national and tribal level, and has led a variety of organizations and efforts that's really, truly impressive. And she has made a commitment to social change and working to address social and economic justice issues that affect the health and well-being of Indian people, as documented in all of her work experience, which we will share with you. So that is it for me. I am now going to turn the control over to Carole to get us started. So hold on one second, Carole. Okay. Carole, if you want to unmute yourself and go ahead.
Okay. If I can I do it through my computer, advance the slide, or do I do it through the?
You can. You should be able to. Yep, there you go. Did you do?
Oh, and you can do animation on yours. Okay. So, well, thank you so much. We're delighted to be doing this webinar with you and to be doing something with Health and Medicine Policy Research Group. Both of our centers are funded by the U.S. Department of Health and Human Services, the Family Violence Prevention and Services Administration, and we're one of the 4 special issue resource centers dedicated to addressing the intersection of, not surprisingly, domestic violence, trauma, substance use, and mental health. And part of our work is to do what we call ACRTI, or Accessible, Culturally Responsive, and Trauma-Informed Practice and Approaches to the DV field, and ACRTI DV-informed work to the mental health, substance use, child welfare, legal, and the other field that is interested. And we do this through a comprehensive array of training, technical assistance, resource development, research and evaluation. I'll share a little bit of our research, policy development and analysis, and public awareness. And so, and we've been doing work, starting in Chicago, doing trauma-informed work since the early 2000s. So we're really excited to be linking up with the Illinois ACEs Collaborative. Gwen's going to introduce NIWRC during her part of the presentation. So, in overview, what I'm going to do is give you some background on the opioid epidemic. When Gwen and I started doing this, people weren't as aware of what was going on, and I think there's been so much in the news and media that many of you may be following all of the trends. But we'll do a brief kind of summary of that and some of the data just to situate the kind of heart of our talk, which is more around trauma and interpersonal violence and the opioid epidemic. And then Gwen will talk about some of the unique issues facing rural, tribal, and other cultural communities, and then we'll talk a little bit about, she'll talk about promising practices, and we'll talk about some policy recommendations at the end. And when I show the data slides, I'm going to go through them quickly because they're more for the visual impact. But there's wonderful graphs and data that you can get from the AMFAR website, NIDA, National Institute on Drug Abuse, the CDC, and SAMHSA. Why now? Why is there so much attention? One is that there are high rates of opioid non-medical use and addiction, and the rates have increased exponentially over the last 10 years, and which has been great cause for concern. They're also high, but when we look at data on substance use and addiction in this country, there are much higher rates of alcoholism and marijuana use, but it's that the high rates of overdose-related deaths that has brought this really to the forefront. There's also the issue of changing demographics, and as many of you are aware, that part of why there was such an interest in the opioid epidemic was because it was affecting white, rural, and suburban communities, often young people, and then older people who are working in areas of economic deprivation, where in economic slumps in Appalachia. So, but as we know, and we'll show you some of the data, that is no longer the case, and there were clearly epidemics affecting communities of color, opioid epidemics in the 70s that didn't receive this kind of attention. So all of the differential responses of the upside being that this is generate a much more compassionate and public health and clinical response rather than a criminal justice response. We're still dealing with many of those disparities in the response to the opioid epidemic. Another thread of concern of why there's been a lot of interest now is because concerns regarding women and opioid use, particularly around pregnancy and what neonatal abstinence syndrome or neonatal opioid withdrawal syndrome. So we'll talk a little bit about that. And then the issues for everyone, for all of us, around limited access, both to prevention and to treatment and resources. So just to go through some of this in a little bit more detail, first of all, the high rates of opioid use. This is from SAMHSA's 2017 NSDUH survey, the National Survey on Drug Use and Health. So this came out in 2018. It's the 2017 data, and it's a household survey, and it's people 12 and older of over 67,000 people. And so in 2017, what we saw was that there were 11.4 million people using opioids other than prescribed, about 4% of the population. And 11.1 million were using it, opioid pain relievers, prescribed or non-prescribed pain relievers in the last year. It was about 10.5 million used pain meds only, about a little over 500,000 used pain meds plus heroin, and about 224,000 people used heroin only. And you can see in the center, this was in 2017 data as well, that 2 million people started to use prescription pain relievers. 1 million people started to use cocaine, and 81,000 started using heroin use. So that is continuing to rise. When we look at the high rates of opioid overdose deaths, one of the things that's interesting is you can see that they're continuing to rise. But that what the cause of those deaths has changed So the green line, if you can see it, was the initial rise related to prescription opioids. And then you can see how that started, the trajectory of heroin-related opioid deaths started to increase in 2010. And now what we see in 2013 is the synthetic opioids other than methadone, which is really fentanyl and carafentanil, and which is 100 times as potent, and some of the other fentanyl derivatives. In fact, when you look at this, this is one of the slides I find really interesting. And again, looking at the three waves in the opioid epidemic. So starting in 1999, there was the rise in prescription opioid overdose deaths. And for some of you who've read some of the really interesting articles in the American Journal of Public Health, looking at even before, initially in the 70s, people were overprescribing opioids for pain, and then there was a swing in the opposite direction where people were underprescribed, and then JCAHO paid the fourth vital sign, so people were starting to prescribe again. And part of the rise in opioid prescriptions had to do with pharmaceutical industry finding an opening to increase their profits, but also some of the nonsteroidal anti-inflammatories were found to create some cardiac problems. People were living longer with chronic pain. So there were lots of reasons why there was a rise in prescription opioids. And then the second wave was heroin, where people were addicted to prescription opioids and couldn't afford them, and heroin was a lot cheaper. And then in the third wave, where heroin is now being laced with fentanyl, as are other kinds of drugs like cocaine and pills. So people are dying from the synthetic opioids often, or other drugs that are laced with synthetic opioids. So when the next couple slides, I'm just going to go through quickly just to give you a visual picture of how things have changed. So this is 2002 data of the increase in opioid deaths by county, and this was the 2014 data, which was the last time I could find a map like this. You could see the dark red is, or orange is where the rates were greater than 20 per 100,000. And you can see Illinois, that there are some pockets of that. When you look at the state data, well, before I go on to the state data, we look at Cook County. Cook County has the highest rate of drug-related deaths in 2016 in the U.S. So I just want people to see that, since this is because we're talking about Illinois here. And again, this is the drug-related deaths per 100,000 by state in 2010. And then you can also see the increase, including in Illinois, in 2016. So one of the things that we just touched upon was that this was largely perceived as a primarily white epidemic initially, and we can look at the rates of drug overdose deaths, and you can see for American Indian communities, which Gwen will talk about, the rate is just as high as among white people, and and is rising at just a higher rate. And we also see that more recently, the rates of death in the Black community are also increasing at a very rapid pace, and as well as the Hispanic community. So we're really looking at an epidemic that's cutting across race and class lines, and that we need to be looking at what kinds of responses we're having and to whom. Again, looking at the states with the highest rates of opioid overdose deaths among whites and African Americans in the general population, you can see Illinois is among the top states. And again, that raises, questions about public perceptions of the epidemic and public responses, and what types of responses. And the concept of diseases of despair. Some of you may have heard about this. Again, that people who don't have jobs, who have chronic pain from work-related injuries, who are dealing with addiction, suicidality, and depression, and the increasing rates of early death among older white men. When we think about diseases of despair, I think we really need to expand our concept of that and what that means for other communities that have been marginalized or dealing with structural violence and other kinds of disparities. When we look at past year non-medical use of prescription pain relievers among lesbian, gay, and bisexual versus heterosexual adults, again, you can see much higher rates of prescription opioid use, and that's often associated with trauma, stress, and discrimination in earlier age of use. When we look specifically at women and the nexus of opioid use in women, there was, again, women were more likely to be overprescribed opioids, particularly between 2008 and 2012. Over a quarter of privately insured women and over a third of women on Medicaid received opioid prescriptions. That women are more likely to use prescription opioids in ways that were not how they were prescribed. And one of the things we talk a lot about at our center and our part of the world is the use of language. And we're talking about non-medical use. In the DSM, it's misuse, opioid misuse, and misuse, even though that may be better than abuse, still has some pejorative connotations. We know that people use drugs for lots of reasons, and mainly to feel better, whether it's for physical pain or emotional pain. In fact, the majority of people who quote unquote misuse opioids, it's for managing physical pain that is undermanaged. And that women tend to use opioids in combination with other drugs, especially benzodiazepines, and the majority of benzodiazepine-related deaths are often combined with opioids. And although more men die from drug overdoses than women, there was a dramatic increase in the rates of opioid overdose deaths for women between 1999 and 2010. And then, although the rates have leveled off somewhat, they continue to increase for both women and men. That they're very similar when you look at prescription opioid use and cocaine, but not for, the difference seems to be in heroin use, that men are more likely to use heroin than women, even though rates of heroin use among women is increasing. And again, the greatest impact is on Native American communities. And this is just showing the changes for women up to 2015, all opioids, and again, increasing risk from heroin and synthetic opioids. When we look at women opioids in the context of trauma and interpersonal violence, we see that women have higher rates of gender-based violence, childhood sexual abuse, plus depression, PTSD, and painful chronic medical conditions, all of which can lead to chronic opioid use. And they're more likely to be prescribed opioids for chronic pain, for physical and emotional pain, given higher doses and used for a longer period of time. A study we did at Cook County Hospital in the ER, and I think in the 80s, we found, looking at medical records for where people didn't recognize intimate partner violence, we found that when it was clear to us from reading the records, survivors were much more likely to be prescribed psychoactive medication, whether it was pain medication or other psychotropic drugs, even if no one recognized what the source of the pain was that they were experiencing. That women are more likely to initiate hazardous use, particularly after they're introduced by a partner. For men, it's more likely to be through a friend or colleague. And women are more likely to self-medicate to manage distressing feelings. So the self-medication aspect to deal with traumatic effects of abuse and violence are much more likely to occur for women, although they happen for men as well. And higher risk for addiction and opioid overdose. So one of the things that's different biologically for women is what's called telescoping, that women physiologically experience a shorter time to become addicted and more likely to have cravings. So they're at greater risk for the consequences and medical complications of opioid use than men are. And opioid use is also a major risk factor for pregnancy-related deaths. So I want you to keep these in mind, because these are all factors that are public policy concerns as we start to talk about the role of gender-based violence in the mix. So, and again, when we look at opioids in pregnancy, we know that there's also concern because there's been a dramatic increase in women being prescribed opioids during pregnancy and neonatal abstinence syndrome. And so one of the policy concerns around this is that we know that medication-assisted treatment is the treatment of choice for opioid use disorder during pregnancy, not forced withdrawal. Yet in 24 states plus the district, substance use during pregnancy is considered to be child abuse, and in 23 states plus DC require mandatory reporting, and 7 states require drug testing if you suspect it. And yet we know that infants with neonatal abstinence syndrome do much better when they're connected with their mothers, and women do better when they're connected with their children, if their children are able to be in treatment with them, particularly in residential treatment settings, and more likely to stay in treatment and maintain recovery. So again, this is a big public policy concern as we're grappling with what does it mean to take a trauma-informed public health informed, resilience-informed approach to addressing the opioid epidemic. Again, access to treatment is a big issue. There are three main kinds: medication-assisted treatment, and again, I'm not going to go into the details of the different kinds of treatment, but they all work for different people under different circumstances, and people really need to have access to all three, and so that the treatment can be tailored to their particular needs. The non-pharmacologic forms of treatment are really important, and these are the holistic, gender-responsive, trauma-informed, culturally resonant, LGBTQ2SIA affirming treatment that really meets people as whole people. And we know that there's just not enough of that, including two-generation approaches. And the last is the overdose prevention, naloxone, harm reduction approaches, safe injection sites, and this wonderful activity, as many of you know, in Illinois and Chicago around those issues. But when we look at access to treatment, from the 2017 NSDUH survey, 20.7 million people needed treatment, 4 million received any substance use treatment, and only 2.5 million received any specialty substance use disorder treatment. So we know many areas, some people don't want treatment, but many areas lack services. 1 in 3 in this study said that they didn't have any insurance coverage. And one of the other issues is really disparities in access to treatment. So we know, some of you may have read the articles in the New York Times last year about access to MAT in New York City, and that communities of color had access to methadone, which is much more restrictive. You have to go every day, and it really disrupts your life, whereas people who had private insurance or could pay out of pocket had access to buprenorphine, where they could get a prescription and then have it filled and not have to go every day. So again, some people don't have access to any treatment. And this is a slide from showing that the access where people had access to all 3 types of MAT in the U.S. And again, it's very limited, and hopefully some of the money that's coming to states now will be able to address that, including to federally qualified health centers. So when we consider the data in context, there are a couple things to think about. One is chronic pain and opioid overprescribing. So there's the role of the pharmaceutical industry and the kind of predatory behavior of targeted overprescribing and sheer greed. But then there's the impact of policies to restrict the supply of opioids, which has then led people in chronic pain, it's increased rates of suicide. We've talked to people who run addiction treatment clinics or methadone clinics and say they're seeing people who are chronic pain refugees because they can't get access to pain, and methadone actually also treats chronic pain. So again, thinking about the balance and the wide swings that we've seen. Overprescribing versus social determinants. So there's the overprescribing, and then there's targeted overprescribing to areas where people are likely to have reasons why they would want to self-medicate and take more opioids, whether it's from chronic pain, from work-related injuries, or from despair. And so thinking about that trauma and the diseases of despair and looking at factors that contribute that are social and political in nature. And then there's the clinical public health versus criminal justice approach and the differential responses, and who has access to treatment and resources and who has to deal with incarceration as a response to substance use and substance use related crimes. And the last thing that we want to shift our focus to is the role of intimate partner violence and gender-based violence. So the role of coercive control in people's use of substances, gender roles, and trafficking. So let's look at that. So when we look at trauma in general and look at the adverse childhood experiences, and I'm not going to spend a lot of time on this because I know you are all very familiar with the role of ACEs in people's health and well-being and substance use as well. But this is just to summarize that there's a dose-response relationship between the number of ACEs and early initiation into illicit drug use problems, addiction, IV drug use, lifetime overdose, and including developing substance use disorders later in life. when we look at the connections around IPV and lifetime trauma and opioid use, we know, again, as I mentioned, this is in the slide about women, but this is amplified in the context of abuse and violence, the high rates of depression, PTSD, suicidality, chronic pain, substance use, and opioids. And again, there's a kind of syndemic quality of them all amplifying each other as well. We also know that there are high rates of abuse and violence and trauma among people seen in substance use disorder treatment settings, including methadone treatment settings, high rates of substance use among people seeking services for DV, and that self-medication is common. But what people don't always know is the role that abusers and traffickers play in actively undermining their partner's sanity and sobriety, trying to control their partner's ability to engage in treatment, actively sabotaging their partner's efforts at recovery, and then turning around and using that to discredit their partners with potential sources of protection and support, including orders of protection, jeopardizing custody, or anything that they can leverage against their partners. And then turning around and exploiting their partner's substance use for either personal gain in an interpersonal relationship or financial gain in a more trafficking context, or just interpersonal exploitation. So this is data that I wanted to share with you from a study we did with the National Domestic Violence Hotline in 2012. And for over 3,000 callers, these were women callers, 26% had used substances to reduce the pain of partner abuse, and 27% had said they'd been pressured or forced to use alcohol or other drugs or use more than they wanted. So that that's the piece that we don't often think about, and any kind of opioid-related policy or treatment needs to factor that in. Of the 15% who tried to get help for their substance use, 60% said their partner had tried to prevent or discourage them from getting help, that they would harass them out of treatment, they would have drugs or alcohol at home when they were in recovery, they would pressure them to use. 37% said then their partner or ex-partner had threatened to report their substance use to someone in authority to prevent them from getting help they needed. We heard stories of women who said their partners would force them to take drugs and then videotape them when they were under the influence and then use it against them in a custody battle or report them to Child Protective Services. And that almost 25% said they were afraid to call the police. And we think about who is literally left holding the bag when the police come. We also hear stories of women they're out on parole, their partner just pressures them until they use, and then they leave and call the police on them. So anything you could think of, these are just a few examples. When we think about this in the context of the opioid epidemic, in addition to introducing a partner to drugs and forcing to safely use the needle the second time, which is where safe injection sites can really be protective, or forcing a partner into withdrawal or threatening to force them into withdrawal becomes a huge leverage point and a way to coerce a partner into engaging in illegal activities, including dealing drugs, theft, and prostitution. It's also an important gateway into trafficking. We think another way this can play out is stalking when someone's going to a methadone clinic every day at the same time. It's much more easy to stalk them, and then blaming the abuse on the partner's use, and then benefiting from the stigma associated with substance use. And that's going to impugn a survivor's credibility. We also think about relapse triggers and the neurobiology of addiction as we're thinking about the neural circuitry involved in creating and maintaining addiction. We think about the things that are relapse triggers and the exposure to addictive and rewarding drugs, cues from the environment, exposure to stressful experiences. You can think about all the things that an abusive partner does to actually create those triggers. So again, they can be deliberately engaged, and it's a way of thinking about how what happens in our lives and environments can impact our neurobiology. So again, this is just a way of looking at this all together. There's the traumatic psychophysiological effects of abuse, the active undermining of a partner's sanity and sobriety, then controlling access to treatment, then using it against them. But the other piece to keep in mind is the role that stigma associated with substance use and addiction plays, that abusers can actively leverage that. So we've talked with lots of judges who are very savvy about intimate partner violence, and when they see someone in court, when they're making a custody decision, that who are they going to give a child to? The person who looks like they're in great shape, or the person that they've been abusing for years. So again, thinking about that as a red flag to consider whether coercion's involved, as well as ongoing abuse. When we don't respond to that, then we're just contributing to an abusive partner's control. So when we look at these together, we're looking at multiple pathways and multiple risks. So there's abuse and violence and trauma, the sequelae of trauma and chronic pain, and then the specific, so there's the overprescribing from, physicians in the drug industry, self-medication and coerced use, and then a shorter time to addiction. So how all those come together to create addiction. And then the limited access to treatment that's accessible and good pain management, plus sabotage recovery and the role of stigma. So those come together. And then the risk for sexual coercion and human trafficking and incarceration, deportation, and child welfare involvement. So I'm going to end this section by bringing it out one more level to the political and structural level. So there's the financial factors driving the epidemic of, greed from the pharmaceutical industry, political factors around the various phases of the opioid epidemic and political suppression and incarceration versus public health responses, and then the interpersonal gender-based violence factors of whether someone is benefiting by creating addiction in a partner and then using that as a way to control them, whether it's for their own personal gain or as a trafficker who is using that for financial gain. So again, we're thinking about this on multiple levels, the individual trauma, the external conditions, and the social political factors. So now I'm going to turn it over to you, Gwen.
Great, and I'm just going to hand over control to Gwen.
Okay.
Gwen, you should have control now.
Okay, I can just use the arrows on my computer, right?
Yep.
Okay. Hello, everyone. My name is Gwendolyn Packard. I'm a Hanktawan, Dakota, and I'm the Training and Technical Assistant Specialist with the National Indigenous Women's Resource Center. And as Carole mentioned earlier, we're both FIPSA funded, and we're both national TA providers. And we have a website that shows all our archived webinars and all our resources and announcements and all the information about our organization on there, if you would like to check that out. See, my arrow's not working.
You might have to click on the slide and then do the arrow.
Okay, I see it down at the bottom now. Okay, all right. So talking about opioids and domestic violence, I just wanted to talk a little bit about rural, tribal, and cultural considerations when we look at this epidemic. First, tribes share many of the challenges and opportunities of rural communities when it comes to opioids, such as access to treatment and resources. And although much of my presentation focuses on tribal communities, they're not too different from rural communities, except in the cultural approaches that they use to address it. Addressing the opioid crisis means confronting socioeconomic disparities. We cannot address this evolving crisis without also addressing the loss of hope and opportunities that have intensified the demand for drugs among those who have experienced countless losses in their lives. Reversing the opioid crisis will require addressing economic disparities, including housing instability, employment opportunities, scarce or inadequate resources, and lack of access to quality health care that currently plagues many of our tribal and rural communities. No, I went too far. Okay, so the opioid crisis is a huge public health issue all across Indian country. In 2014, the incident rate ratio for opioid-related deaths among American Indian Alaska Natives ages 15 to 64 was higher than all other racial groups in the U.S. 1 in 10 American Indian Alaska Natives ages 12 and older used prescription painkillers for non-medical reasons. And American Indians, Alaska Natives are twice as likely as the general population to become addicted to drugs and alcohol, and 3 times as likely to die of a drug overdose. Opioids are highly addictive. It doesn't take long to become addicted. A broken leg, an injured back, a car accident. We hear these stories all the time of people sharing how they became addicted. As seen in this chart, as well as several of the charts that Carole showed, American Indian Alaska Natives face the highest rates of overdose in the country. In one small tribal community of 300, 12 people died from overdose in the past year. You can see what a devastating effect this is having. Also, we saw in Carole's slides, there's a dramatic upswing in overdose from opiates across all peoples. Here in New Mexico, we've been in the top 10 in the nation for drug overdose deaths since 1991, and it's only been recently that we dropped to 12, and I believe that was in 1916 we dropped to 12. This might seem like success, but authorities here are quick to state that it is most likely that other states, especially the ones we saw on the maps that Carole showed, are seeing tremendous increases in overdose deaths due to opioids, including heroin and fentanyl. So it wasn't so much that we were doing the right things here, but it's that it's excelling in other parts of the country at higher rates. When I first started doing this presentation with Carole, and I went all across country asking everyone, you know, what about opioids and how big a problem that was in the communities. The common theme I heard from many programs was opioids. We're dealing with meth on a grand scale here. We need help with that. And although meth causes serious physical, behavioral, and neurological changes and dangerous environmental concerns, it doesn't have the fatal consequences associated with opioid abuse. Both drugs are highly dangerous and addictive, but people aren't dying from meth at the rate that they are dying from opioids. The depths of trauma for American Indian Alaska Natives are tremendous, and trauma plays a big role in opioid abuse, be it living in a violent community, in a violent household, experiencing multiple incidents of physical and sexual abuse, or any of the identified adverse childhood experiences. In addition, American Indian Alaska Native people, the legacy of historical trauma has contributed significantly to this problem. From the time of contact, Indigenous people have experienced attempted genocide and ongoing genocidal practices, constant and widespread violence against our women and children, forced removal from our traditional homelands, creation of reservations and relocation to urban areas, boarding schools, removal of our children, forced removal, loss of language, culture, identity, forced sterilization, poverty, racism, and changing federal policies. And perhaps the most devastating consequence of all, internalized oppression, which erodes self-esteem, disempowers individuals, families, communities, depletes trusting relationships, fuels depression, enhances isolation, reduces strategies to overcome and heal, heightens a sense of hopelessness, perpetuates conflict within the family and the community, and contributes to the already ongoing traumatic experience. In our historical legacy, we experienced a period of forced removal of our children. For hundreds of years, federal and state governments have taken Native American children from their parents and placed them in institutions of one kind or another in an effort to civilize the savage born. This practice and policy left many of those children and their families psychologically battered throughout their lives and across generations. In addition, for American Indian Alaska Native people, the legacy of historical trauma has contributed to this problem. And I think the really big thing here is the violence against Indigenous women is really at the point of critical mass. As Indigenous people, our women experience the highest rates of violence. 3 in 5 Indian women will be physically assaulted in their lifetime. Indian women suffer from violent crime at a rate of 3.5 times the national average. Homicide is the 3rd leading cause of death for Indian women. 75% of Indian women murdered were likely killed by an intimate partner. And women on some Indian reservations and in Alaska Native villages report rates of domestic violence up to 10 times higher than the rest of the US. During congressional field hearings on the Defending Childhood Initiative in Alaska, it was shocking to note that in some villages, 100% of the women were raped and experienced sexual assault and violence. In the US, there are 567 federally recognized tribes representing approximately 3.3 million American Indians and Alaska Natives. The Indian Health Service is a main provider of health care, including behavioral health care services, for 2.2 million American Indian Alaska Native people in this country. There are fewer than 200 healthcare facilities, including 34 urban or off-reservation centers and 25 hospitals in the United States to meet the healthcare needs of our people. There is limited access to healthcare, let alone mental health care and treatment programs. Given this disparity, along with the bottomless pit of trauma we see across our nations, it's easy to see why this opioid crisis is especially devastating. What are the connections to domestic violence? These 3 categories stand out in what we are seeing across our nations and in communities, rural communities, with regard to opioid use. Self-medicating to deal with the trauma, coercion, and I know Carole addressed some of these in her presentation. Trafficking, opioids either led them to being trafficked or keep them in this cycle of exploitation. We are seeing how these drugs are being used intentionally to the detriment of our people and our communities. Clearly, more resources devoted to addiction-related problems are necessary. This is a theme we hear over and over, the need for more resources. When we look at the high rates of domestic violence, 40% of victims have no access to resources, and most tribes have almost no resources to address the opioid crisis. This is a quote by Sarah Deer, and I think it's rather alarming. If you're a trafficker looking for the perfect population of a people to violate, Native American women would be a prime target. You have poverty, you have a people who've been traumatized, and you have a legal system that doesn't step in to stop it. We're just now beginning to see more better data with regard to sex trafficking, but it's clear that American Indian and Alaska Native women are disproportionately impacted. The data shows the majority women of color, majority youth, and children. There are clear connections between trafficking, poverty, migration, gender, racism, and racial discrimination. With regard to ACE and American Indians, because of all the past, present, and ongoing trauma in the life of so many Indigenous people, it's not unusual to find whole communities where there are 8 or more ACEs. Just a quick run through of the ACE factors shows the following. In terms of physical abuse, American Indian Alaska Native children are overrepresented in the foster care system due to child maltreatment. With regard to emotional abuse, higher rates of disruptive behavior and substance use disorders than other same age children and youth. Sexual abuse, high rates of sexual victimization, alcohol and other drug abuser in the household. National statistics reveal that 13% of American Indian Alaska Native adults are drug dependent, compared to 9% for non-American Indian Alaska Natives. Incarcerated household member, American Indian and Alaska Native adults have a 38% higher incarceration rate than other groups. This does not address the number of incarcerated American Indian and Alaska Native juveniles in state and federal custody, and the number of American Indian and Alaska Native adults on probation, parole, or under the custody of law enforcement in other legal status retention, such as tribal jurisdiction. Someone who's chronically depressed, mentally ill, institutionalized, or suicidal. American Indians and Alaska Natives have the highest rate of suicide for all groups. In addition, they lead the nation in death due to injuries and homicides. It's understandable that this is correlated with high rates of depression, anxiety, and PTSD. Mother is treated violently. I just showed the high rates that American Indian women experience in terms of violence. One or no parents. 53% of our population, of our children, are living with one parent, according to the National Kids Count data. Emotional or physical neglect, according to the National Indian Child Welfare Association, American Indian and Alaska Native children have the highest rate of neglect for all populations. Soul wounding refers to the tremendous impact of all the past traumas we have experienced as a people. Multicultural social justice counseling theorists and researchers suggest that the disproportionately high levels of substance abuse, domestic violence, and suicide among American Indians today is partially due to a failure to heal the soul wound that was transmitted intergenerationally as a result of the historic trauma that our ancestors experienced. In addressing the trauma for ourselves and our families and communities and reclaiming our culture and traditions are highly effective in creating healthy people and healthy nations. Looking at and understanding intergenerational trauma is one of the first and most important steps we can take. And I really like the little saying here, to understand how to move forward, we must first talk about what has happened. And that's proven highly successful in terms of addressing the historical trauma that a lot of our communities face. In our Indigenous way of thinking, all things are related, all things are connected. Indigenous people are quick to recognize the connections between domestic violence, trauma, healthcare, AIDS, HIV, child welfare, trafficking, mental health, and substance use. It's important that we are holistic in our thinking and in our approach to not only understand the connections between our mind, body, and spirit, but our connections with the larger cultural community and environment of which we are an important part of. And I just want to close with a word about harm reduction. Harm reduction in the traditional sense means keeping our community safe and reducing the harms we face, using tools that work best for our people, using substances without stigma and without judgment. It may mean keeping one another safe while using substances. It involves community-wide efforts to reduce everyday risks and harms. It means addressing safety in unsafe situations. And I had one more slide on promising practices, which I'll try to make as quick as possible. But
you can take longer.
Well, we won't have time for questions.
It's for people to hear about some of this. Yeah.
Well, I think it's some of the things that Carole had already mentioned, but community education and awareness, we have found in one community, just providing information about opiates and how highly addictive they are has made a tremendous impact in reduction in overdose rates. So the more people know, the more that they're aware, and the better able they are to address this. there's a whole number of states that have introduced opioid stewardship fee bills, and more than 250 cities, towns, states, hospitals, labor unions, and tribes have filed lawsuits against opioid manufacturers and distributors for their role in creating this crisis on allegations of deceptive marketing, fraudulent and negligent conduct, and violations of the Racketeer Influenced and Corrupt Organization Act. It's hard to say. For the most part, they are primarily seeking monetary damages to pay for treatment programs which are scarce, inaccessible, or non-existent in most places. Certainly, big pharma and overprescribing have played a huge role in this crisis, but as communities have become more educated and aware of the dangers and fatal consequences, we have seen safer prescribing practices, including prescription drug monitoring programs. And of course, more and more communities are providing naloxone or Narcan along with training to prevent overdose deaths from happening. And I think the healing to wellness courts are proving to be highly effective because they offer treatment and traditional healing opportunities as opposed to punitive or a criminal justice response. And I think everyone seems to agree that medication is absolutely critical before any counseling or other work can be effective. And finally, healthcare, behavioral health, and treatment programs, the criminal justice system, law enforcement, pharmaceutical companies cannot address this epidemic while working in silos. We have to come together to strategize how we can work with people with substance use issues and help them get the assistance and support that they need. I think it's back to you, Carole.
Yeah.
Okay.
So I'm going to go through these last couple of slides quickly because they're very self-explanatory. I put everything on the slides. So one thing is just thinking about the impact of trauma, interpersonal violence, and substance use coercion, and all the things that we think about around the opioid epidemic, initiation into use and addiction, all the complications, access and ability to engage in treatment, maternal mortality. This is an issue in Illinois with a wonderful violent death mortality review committee, involvement in all of the systems, and then in initiatives that as the Illinois ACEs Collaborative, you are probably all involved in around individual and community resilience and well-being, and thinking about the role of all of these factors in those initiatives. This is from our toolkit for responding to mental health and substance use coercion in primary care and behavioral health settings, and it's really, it gives you guidance and tools for how to really incorporate this into clinical practice. And partnering with DV and sexual assault programs is really critical. And then at the end, thinking about policy and prevention, thinking about factoring all of what we've been talking about into harm reduction strategies, needle exchanges, opioid hotlines, Good Samaritan laws. How do we factor all of this in? Health and behavioral workforce trainings, insurance coverage is really critical, and community resilience initiatives I just mentioned. So also thinking about data collection, for those of you who are involved in public health, and thinking about coercion, the NSDUH this time started to talk about initiation into use and why people use, and what the reasons are for not accessing treatment, but there aren't questions around coercion and some of these other factors that could be part of those data collection initiatives. Again, making sure that there's really comprehensive, holistic approaches to both in treatment settings, including settings where women can be with their children, which makes a huge difference, but also community-wide initiatives. And then making sure that all of us are at the table in shaping the policies and practices at the local, state, and federal and tribal levels. So thoughts, questions?
So I just want to, this is Laura speaking again, and I just want to remind people to please go ahead and type any questions that you have for our presenters in the question or the chat area, and we can go ahead and ask them. I want to say thank you so much. This has been, you guys have packed in so much information, and it's been really so helpful to hear all of this. I guess I'm just checking to see if there are any. Oh, we have one question. Can we hear a little bit more? Oh, go ahead.
No, ask the question. I was going to suggest something if there wasn't one.
Sure. No, can we hear a little bit more about the Healing to Wellness Court was a question we had. Gwen, I think that one is directed at you.
Yeah, it's just I was referring to the ones that I'm familiar with in tribal communities, and they're those communities that often are able to take advantage of a lot of our traditional and cultural approaches to healing. So, sentences might be, if someone's coming into the Healing to Wellness courts, it might be something like they need to get up every morning, pray and run, or something like that. It might be something, or they might need to attend talking circles, or it's just different ways that they feel that it'd be most beneficial for this person, other than throwing them in jail, which is oftentimes what happens to a lot of people who are, come to court for on drug charges for possession or, whatever. But in these situations, they're able to do some things that'll help that person heal rather than punish them. It takes into consideration the trauma that this person's experienced, why they're involved with drugs, and a number of other factors.
And I think one of the things that's so important that you really talk about so eloquently, Gwen, is that kind of holistic approach, that it's not just treatment of a disorder, there's a whole person with a whole complicated life and structural things in their lives and historical things that have come to play, that unless we develop strategies for addressing all of that together, we're not going to be able to turn this around. And I think the models from tribal communities that have taken this on as a community are really inspiring and important to think about for everyone. Like one of the things when we first started talking about this was like, if everyone in a community has an ACE score of 8 or 10, that's no longer just an individual risk factor, that's collective, and that the solutions need to be collective as well. And I think the examples that you bring to light are really important. So I just wanted to say that.
Thank you. Another question that we have is if you have any suggested literature around these topics, or specifically like the policy issues or trainings that you've enjoyed. There was a question around that. So perhaps you can give us, if you have some ideas, we could send that out with a follow-up email that's going to go out, which will also send the slides and some contact information.
We have a whole webinar series on opioids, trauma, and domestic violence that you get the link to the archive webinars and the handouts on our website. We're partnering with the Campaign for Trauma-Informed Policy and Practice, of which some of the National ISIS connections people are part of. And Gwen and I have done a number of talks and webinars that are some on the NIWRC website and some on ours. And we have a whole list of resources, and one of the slides has them on our website. And Gwen, you have a lot on yours as well. So,
great. It looks like we're just about out of time. Carole and Gwen, do you have anything more you want to say before I close us out?
I just want to thank everyone for tuning in today and listening to us, and that I think our contact information is at the end of our PowerPoint, which is also available to everyone. If you have any questions, or if there's anything we can help you with, please feel free to reach out and get in touch with us. I want to thank everyone.
Yeah. And I would say the same. And also, I would really look forward to hearing more about what the Illinois ACES Collaborative is doing around these issues, and to partnering and talking further. So thank you all.
Yeah, great. And thank you to our speakers again so much. We are so honored that you joined us for this webinar to share all of your information. This is really so helpful for us to hear. I also want to thank quickly our funders who support this webinar series, which includes the Illinois Children's Healthcare Foundation, the Otto S.A. Sprague Memorial Institute, the Telegen Community Initiative, Prince Charitable Trust, and the Albert Pick Jr. Fund. Stay tuned. We'll be sending out a follow-up email, as we mentioned, with the slides, with the survey, and a link to our website and resources. If you're new to us, we hope you'll sign up for our newsletter as well, so you can stay informed about everything that's going on with the Illinois ACEs Response Collaborative. So on behalf of the collaborative, thank you so much again to Carole and Gwen, and to all of you for participating today, and we will be in touch soon. So take care and have a good day.
Great. Thank you.